Okay, now I'm sharing my slides. I think everything is good. If it's good for everybody, so I can start now. Okay. Hello, ladies and gentlemen. My name is Elahe Baharvand, and I'm your host today. I'm assistant professor of internal medicine at Shariati Hospital, Tehran University of Medical Sciences, Iran. As you might know, we have had our first session of CPC, Case Presentation Conference, in February. And if you did not have the chance to be online with us, still you can get to watch the recorded film in our website. And today we are going to have an exciting case of respiratory and renal failure together. Now I want to salute my dear friend and colleague, Dr. Bijani. Dr. Bijani is also an assistant professor of internal medicine. She's also head manager of educational development office at Shariati Hospital. Dr. Bijani.
Hi, everybody. It's a great pleasure to join you here, and it's a great pleasure to meet these nice professors. I'm here to monitor your questions, and don't hesitate to ask any question, and I will ask it from the professors in convenient time. But please be aware of your ID name, that it could be completed, and your legal name to have certifications. And any of dear professors, if they have any problem, please text in chat box, and I will monitor that. Thank you.
Thank you very much, dear Faiza. I'm having some problems with the slides. Okay, our first speaker, our dear Professor Dr. Tahireh Faizi, who is the head of the course. She's professor of rheumatology. She's also head of rheumatology division in Shariati Hospital and head of connective tissue disease unit in Rheumatology Research Center, Shariati Hospital, Tehran University of Medical Sciences. Our invited speakers, first we have Dr. Arezu Khosrowshahi, who is an associate professor of medicine, rheumatology division, and also director of clinical trials at Emory University School of Medicine, United States. We are also very pleased to have Dr. Marjan Afrouzian, associate professor of pathology at University of Texas, Galveston. We have Dr. Pedram Ahmadpour with us, who is a nephrologist at Department of Nephrology, Dialysis, and Apheresis at CHU Nimes, France. And we are also having Dr. Mohsen Dawoodi with us today, who is a professor of clinical medicine and director of interventional pulmonary service at the Division of Pulmonary Critical Care and Sleep Medicine, Renaissance School of Medicine, State University of New York, Stony Brook, New York, USA. Also, I would like to really thank Dr. Marjan Yaghmai, Associate Professor of Medical Genetics, who is also the head of Iran North America Academic Partnerships, who has her full support for our course. Okay, thank you all for participating, and I hope you enjoy this session. The case that we are going to discuss today has been taken from New England Journal of Medicine. The chief complaint of our patient was dyspnea. He was a 35-year-old man who was admitted to hospital because of dyspnea. The patient had been well until several weeks before admission when fatigue developed. 2 days before admission, dyspnea developed and worsened without any fever, cough, or chest pain. Early on the day of admission, he went to an urgent care clinic, and we have the report of that encounter. At that time, he had been in respiratory distress with a respiratory rate of 36 and oxygen saturation of 91% in the ambient air. He had not been febrile. His blood pressure had been 152/79, and his pulse rate had been 102. He had been pale, but on chest auscultation, there had been no rales or wheezing. So they had administered oxygen by face mask with a flow of 15 liters per minute, which resulted in oxygen saturation of 95, but changing the flow to 6 liters per minute caused O2 saturation failing to 81%. So within 15 minutes of his first presentation, he had been transferred by ambulance to an emergency department. The patient reported fatigue, shortness of breath, and during the previous 2 days, decreased urination. But he did not have any cough, chest pain, change in symptoms with position, hemoptysis, fevers or chills, night sweats, headache, visual loss, dry eyes or mouth, or any joint pain. On past medical history, he reported episodes of bilateral finger, ankle, and facial swelling without any pain or change in color during the previous 6 months. He had had one episode of back and suprapubic pain, fatigue, and fever 4 years before admission. At that time, he had had hematuria and proteinuria with a urine culture of 1,000 to 10,000 colonies of mixed flora. Testing for chlamydia and Neisseria at that time had been negative, and other lab tests are shown in the next slide. At that time, he had been prescribed with ceftriaxone, but he did not follow up with his primary care provider as he was advised. 6 years before admission, he had had one positive testing for rapid plasma reagin with a titer of 1 to 8, but he had been tested after that. He had been tested for antibodies to Treponema pallidum, HIV, and PPD testing, which were all negative. Here we have the blood results from 4 years before admission. At that time, we see that he had a white PC count of about 11,000 and a slight anemia. And the urine analysis at that time shows hematuria and albuminuria with 3 to 5 red cells per high power field. Okay, after that, we have the drug and social history. Our patient did not take any medications or herbal supplements. He had no allergies. He was married and had no children. He was physically active in his job. He had no history of recent travel, exposure to sick persons, blood transfusions, or any previous surgeries. He did not smoke, drink alcohol, or use any illicit drugs. On physical examination in the hospital, the temperature of the patient was 36.9. His blood pressure was 173/89 millimeters of mercury. His pulse rate was 95 and his respiratory rate was 36. His oxygen saturation was 88% on ambient air and 100% with high flow oxygen with a non-breather face mask. On physical examination, he was clearly pale and he had slight brownish injection in his conjunctiva. There was a hypopigmented macules on the right temple and both lower cheeks, and hyperpigmented macules on the bridge of the nose. And there were bibasilar rales in the lungs. The remainder of the examination was normal. We have here some primary test results of the patient. Here we have the CBC of the patient, which shows slight leukocytosis with neutrophil dominancy and also some lymphopenia. The most prominent problem in the CBC was a hemoglobin of 4.5. The platelet count was normal, reticulocyte was normal, and the ESR was very elevated, 95 millimeters per hour. On the other test results, he had a BUN of 158 and a creatinine level of 30, but the other tests, such as the liver function test and bilirubin, were normal, and the amylase and lipase levels were slightly elevated. As you can see in the table, the creatinine kinase of the patient was about 3,000, and the troponin T of the patient was elevated. Here we have the urine analysis of the patient, which showed a pH of 6. It was clear. It had 1+ glucosuria and 3+ occult blood and albumin, with red cells of 20 to 50 and white cells of about 10 to 20 per high power field. The VBG of the patient is shown here, which showed acidosis with a pH of 7.10, a partial pressure of carbon dioxide of 25, and a base excess of -20. The electrolytes of the patient are shown here, which showed hypocalcemia and hyperphosphatemia, and the lactate level of the patient was within normal limits. Also, we have the other test results here, which showed an elevated level of parathyroid hormone. The other test that we have here is a D-dimer, an elevated D-dimer of 6,900 with a cutoff of 500, and an elevated fibrinogen level, and also the PTT and PT of the patient were slightly elevated. We also have hypoalbuminemia here. The albumin level of the patient was 2.9, and serum protein electrophoresis of the patient showed diffuse increase in IgG level. The blood and urine toxicology of the patient were negative. And also the stool examination of the patient showed 1+ blood. We have some viral markers here. We have hepatitis B, hepatitis C, and parvovirus B19 level serologies, which were all negative. And also they had an ECG taken from the patient, which showed sinus tachycardia, counterclockwise rotation with non-specific STT changes. So here we have the first chest radiograph of the patient, which showed central opacities, which was more prominent on the right side. So the patient was administered with IV furosemide and continuous infusion of nitroglycerin and oxygen supplementation with BiPAP, or bi-level positive airway pressure. After 2 hours, the patient developed tachypnea, appeared to be fatigued, and had no urine output. So he was intubated and was admitted to ICU. And this is the next chest radiograph of the patient.
Yeah, okay, thank you, Dr. Bahavan, for presentation. And now we have a patient with rapid to progressive pulmonary involvement, rapid progressive glomerulonephritis, and severe anemia that with a rapid drop in hemoglobin. Skin lesion on sun-exposed area, high ESR, and history of the hematuria and proteinuria, and history of false positive RPR. Thanks, Dr. Dawoodi, for joining us. And I have a question from Dr. Dawoodi as a pulmonologist. And now with this problem list, could you please explain this test X-ray and give us your information about the differential diagnosis and your next plan for this patient, please?
Sure. Hello to everyone, and thanks for having me. The 2 chest X-rays are not very specific, or they don't really point to a very tight diagnosis if I ignore the rest of the story. The chest X-rays, if you go back to the first one, it shows a classic, what they call butterfly or bat wing infiltration on the two sides. You could see like a kind of the wings of a butterfly or a bat going out from around the heart. The heart is maybe not borderline a little enlarged, not at all something to write home about. The airways seem to be widely patent. There is, as you can see, a subtle spared rim around the heart that is less opaque than the further out portions. The shape of the infiltrate, from what you can see on a slide on a simple chest x-ray, is fluffy. It does not look reticulated or infiltrated in a chronic sense. It looks much more acute, like an acute change. And that's pretty much all you can say. I mean, the x-ray doesn't really look impressive other than a very bad pulmonary edema. I mean, this is a picture of pulmonary edema until proven otherwise when you see this, especially in an acute patient who was saturating 92.3% until an hour ago, 2 hours ago. So when this happens acutely, if this had been happening for 5 days, I could give you a much longer list of things to look at. But knowing that the patient was saturating 92% until a couple of hours ago, pulmonary edema is top of the list. And here you see the same patient intubated. The infiltrate is a little worse. You've lost the margin of the right diaphragm, which tells you that whatever process is happening is probably more on the right lower lung field than the rest of the chest. You see a kind of a maybe not. I don't know if I can. Do you see my? No, you don't see. I'm not sharing my screen, so you have to point it yourself. Above the right diaphragm in the middle portion, there's an area where there seems to be a little bit of a bump there, and that's probably where the most dense part of the infiltrate is. As we said on the prior image, and it's more visible if you compare this one to the last one, there is a pretty decent right to left gradient. The right is significantly worse. It's less significantly worse in the first x-ray compared to the second. So whatever process is, it's mostly sparing the left side to a certain extent. And of course, the arrow is pointing to the tip of the ET tube a couple centimeters above the carina.
Okay, thank you, Doctor.
If I want to put it in a context of the bigger picture, these case reports, many of them are done in retrospect, and many of them are done to fit elaborate diagnostic patterns. And sometimes maybe that's a little bit of an overkill, maybe. At this point, what I'm hearing is mostly this. You see a patient with a 4 to 6 year history of nephritis that's been gradually progressing. You see gradually worsening numbers over time. You see anemia. I disagree that a huge portion of this anemia is acute. I don't think this all happened since last night. This hemoglobin of 3.8 or 4.1 or whatever that was, from a drop from 11.5 or 12. That would require losing about 2.5 liters of blood in an average adult man. If you would lose all that into your lung, you wouldn't be breathing by now. You wouldn't have walked into the ED. And he's not hemolyzing. Some of Dr. Glassick's, I know Rich Glassick, he's a wonderful nephrologist, but I don't think he's a good pulmonologist. And if he would be hemolyzing to that extent that he's saying, you wouldn't have a normal bilirubin. It's almost impossible. I mean, it's not almost, it's fully impossible. And again, you can't bleed 2 liters into your lung and have that chest x-ray, the first part or the second one, or walk into the ED with a saturation of 91%. So I think a lot of this anemia and the nephritic pattern were gradual, and then something tipped him over, and his blood pressure of 180 suddenly also is more pointing to the fact that this was more like a hydrostatic hemodynamic issue that led to pulmonary edema in this gentleman.
And Dr. Dawoodi, thank you. What's your next step for this patient if you have the same patient?
I think as they probably did, which we know they did, it's further testing to see what the reason for his nephritis is. From a purely respiratory perspective, the first things first is you want to maintain his oxygenation and hemodynamics. So it's good critical care, which I'm sure they delivered. And next, as they did again, would be to put a scope in there and take a look to see what you see in the airway. Again, what I would expect to see is mostly frothy pulmonary edema and not much more. If this was right, if we were going in real time, as of this minute of the presentation, I would just expect to put my scope in there and see frothy pulmonary edema, right more than left.
Thank you very much.
Thank you. Thank you very much. Okay. So the patient was taken to the ICU, the intensive care unit. At that place, they had a catheter placements, a radial arterial catheter, and also a left internal jugular triple lumen catheter. And he was prescribed with hemodialysis. And also he received 8 units of PAC cells during 23 hours. The transthoracic cardiac ultrasonography showed normal global cardiac function and right ventricular size with no evidence of pericardial effusion. And abdominal sonography showed normal renal size, position, and echo texture, and normal arterial blood flow. Gram staining of sputum showed abundant leukocytes, very few squamous cells, and few mixed gram-negative and gram-positive organisms. And here we have the CT angiography of the patients. Actually, some of the cuts are shown here. Okay.
Now we notice that the patient has a normal cardiac function and normal renal size and just a few mixed gram-positive and gram-negative on sputum staining. And Dr. Dawoodi, what's your idea about this chest CT angiography?
Thank you. Just to correct my prior response to your last question, before I go on to this, you said, what would you do next? I missed saying, I neglected saying that the first thing I would do would be dialyze the patient. What I forgot to say was the patient comes in with a BUN of over 100, rocket high creatinine, and more importantly, acidosis of, I think the bicarb was down to 4 or 3. If I'm not mistaken, I can't remember the exact number, but I think it was around 4. That's a very dangerous picture in someone who's on a ventilator and not hemodynamically very stable. So I would definitely initiate dialysis for this patient, which they did. I neglected to say that. The CT is pretty much, it proves what we saw on the chest x-ray. It doesn't significantly add to the information. You're not seeing anything surprising on the CT that you wouldn't expect based on that chest x-ray. If you look at the coronal images in that image marked E, you see the exact same bat wing distribution of the infiltration or opacities. You see that the density is more above the right diaphragm posteriorly, which is again weight dependent, so goes back with any infiltrative process that has to do with gravitational factors. You do see evidence of edema. The black arrow in slide D, the picture D, shows fluid in the fissure and granulation of the fissure. It's like BD, which shows that there's fluid accumulation there, especially in a patient without chronic lung disease. And there's a tiny effusion on the bottom of that slide too. The rest of it, it's not particularly, again, striking. You don't see any, as you can see, the upper 1/3 or 1/4 of both lungs, especially the left lung, is completely spared. I mean, if you put a piece of paper on it like this and cover it, I could sell that to you as a normal chest CT if you just see the apex of the left lung and the tip of the apex of the right lung. Again, more pointing to a gravitational issue. So that's all I see in this CT. I don't want to overread it.
Thank you very much. So do we have the next, what is your suggestion for the next step for this patient? Are we?
Dr. Davudi, please turn on your.
I'm sorry, I muted myself. I apologize. I said, as I said a couple of minutes ago, the priority in this patient, of course, would be hemodynamic and homeostatic stabilization. They're dialyzing the patient, which they should. They're transfusing him, which they should. They're fixing the numbers, as we say. After they fix the numbers, to take another step to try to secure a diagnosis, the first step would be just to look inside the airways to see what you find in the airways.
Okay.
Thank you.
So as the next step here, we have the bronchoscopy of the patient, which showed thick red mucus in the main stem and right lower lobe bronchi. The carina and left lung airways were normal, and bronchoalveolar lavage on the right side with 4 serial alkyds of normal saline showed increased red return. Well, in the first tube, they had 300 red cells and about 1,000 white cells, but in the fourth tube, they had 20,000 red cells and 100 and 400 white cells with a predominant polymorphonuclear cells and about 8% macrophages. The gram staining.
May I interrupt you? There was a
sure.
There was an important word missing up there. I think you missed it in typing it out. On the first line, I think it should say thick red mucus in the right main stem, not just the main stem. The presentation pointed out clearly that the left lung was completely dry and not bloody. So that's not the main stem, it's the right main stem.
Okay, thank you. My apologies. Okay, may I continue? Okay, so the gram staining showed leukocytes without any organisms. Testing for fungal bed preparation, staining for acid-fast and modified acid-fast bacilli was negative, and testing for respiratory viruses was negative as well. Cytologic examination showed evidence of acute inflammation and pulmonary macrophages with no malignant cells. Okay, Professor Faizi, do we have anything?
Thank you. Dr. Davudi, according to the results of the bronchoscopy, now what's your diagnosis and your treatment plan for this patient?
When we communicated, you had asked me to kind of give you an assessment at this point of what we would do and what we would think about this. My assessment will diverge a little bit, not significantly, but a little bit from what's in the article. And again, the reason for that is, I'll tell you what I think right now. This is alveolar hemorrhage. I am not sure this is diffuse alveolar hemorrhage. Diffuse alveolar hemorrhage, I've seen a few, something close to scores of it, maybe 100, maybe 150 over my 20 years of doing this. And it's often really, that word diffuse is there for a good reason. It's actually diffuse. You see blood everywhere. You don't just see it in one side and predominantly in one lobe. This person definitely bled into their right lower lobe. The left lung is pretty much spared other than edema on the X-ray and CT. There was no blood on the left side. It's almost impossible to bleed in a lobe and not see it on bronchoscopy, especially a few hours later. It wasn't done immediately after he decompensated. And so, yes, this person had alveolar hemorrhage in the right lung, predominantly in the right lower lobe. But I don't think this was DAH, diffuse alveolar hemorrhage. But assuming that it was a very mild form of DAH or a limited form of DAH, as you folks know better than I, because you are all rheumatologists and you're cerebral doctors, DAH has three main broad categories. That's what we teach trainees and fellows. It's the capillaritis, it's the bland hemorrhage, and then it's the ones that fall into the diffuse alveolar damage ARDS syndrome category. Based on what we know now, as opposed to like meaning this minute of the presentation, if we were really in real time doing this, I would think this is mostly the second one. This is the bland hemorrhage category, not the classic capillaritis vasculitis DAH, based on the limitedness of the issue. If I knew it a little later downstream, as we get to it in the next 10 or 15 minutes, I would think more that I was correct, that this is mostly the bland type and not the capillaritis. And I won't say it right now not to ruin the presentation, but we'll get to that in a second. But just going categorically, capillaritis, as you know better than I, it's essentially infiltrative necrosis of the alveolar wall. The process is a little slower than this. It doesn't happen immediately like this. It doesn't flash like an edema because there's a process of infiltration, alveolar wall destruction, spilling of blood into the interstitium and the alveolar space. And that is the one that is classically associated with diseases like vasculitides and connective tissue disorders and the classic anti-GBM syndromes. The bland hemorrhage is mostly hydrostatic, but there are other factors that can contribute to it. One of them is all the coagulopathies, whether inherent coagulopathies, which are patient-based, or iatrogenic coagulopathies like over anticoagulated patients. Another very common scenario that is not mentioned as much today because of the change of the literature, but may apply to this gentleman, our patient, is uremic alveolar hemorrhage, or what we used to call in the past uremic pneumonitis. These are patients who come, they should have been treated for their nephrological disease like 6 months ago or months ago or years ago, and they're just chronically getting worse and worse. Their blood pressures are more and more, so they have basically fragile alveolar capillaries in one area or the other, and at some point they develop a pneumonitis and bleed out. And the third category, which doesn't really apply to our patient, is the diffuse alveolar damage or ARDS syndrome, which basically hyaline membrane disease. And the acute version of, the rapid version of that would be what we used to call mostly Hammond-Ridge syndrome or acute interstitial pneumonias. And that's a disease primarily of severe oxygenation. And then on the side, because of the interstitial thickening and the hyaline membrane disease, you can develop alveolar hemorrhage as a secondary syndrome. It is not an inherent part of diffuse alveolar damage that you would have to bleed. You could have diffuse alveolar damage and horrible hyaline membrane disease without any bleeding. So being the second one, based on my guess now, what I just told you, my emphasis in this gentleman would be find his disease syndrome, which is his kidney disease, treat that while you stabilize your physiology in the ICU to maintain his homeostasis.
Thank you, Dr. Dawoodi. But in this case, if you notice that patient has some manifestations such as maculopapular rash, increased ESR, and some manifestations that show that this patient may have a multi-system organ involvement. According to your discussion, and the pulmonary involvement in this patient is related to the mainly related to the renal involvement, renal failure. But if we consider all of the manifestations, do you think that capillaritis may be more prominent as a cause of the alveolar hemorrhage? As you know, that some kind of alveolar hemorrhage may be focal, and sometimes they are not so diffuse. And so, what's your idea about this? What's your opinion?
I would have to cheat then. If you're asking me to respond to that question, I would have to cheat. I know what happens next. So let me say that then. I said that I told you that would be my first guess, and then I told you I would be proven right as we go forward. So I have to cheat and go forward in our presentation. As you know, he becomes much, much better in about 36 hours and is extubated. Capillaritis and vasculitis of the lung does not respond to the most aggressive treatment in 36 hours. What responds that quickly is pulmonary edema and hydrostatic issues of the lung. I have never seen a true capillaritis alveolar hemorrhage that responded to treatment in 36 hours and the patient was extubated. So his drastic response to treatment, his drastically favorable response to treatment, is what tells me that if I had to put money on this, the bleeding we saw in one lobe was not capillaritis. But again, I'm only guessing as much as you are or anyone else are, because we don't have a lung biopsy on this man. So we are going based on clinical findings, based on the fact that when he was transfused, dialyzed, and giving glucocorticoid in 36 hours, he got off the ventilator. That wouldn't happen in capillaritis. You wouldn't see that.
But what about the involvement of one part of the lung? Bland hemorrhages can be involved just one part of the lung, or it could be more diffuse.
Absolutely. We don't know why, but that happens. As you know, and all of you with some, even a couple of years, but you folks are more experienced than that. All of you know that we don't know why CHF is not as diffuse always as it would be. We've seen congestive heart failures that they have a massive pleural effusion on one side, transidative, and the other side is completely spared. We all see flash pulmonary edemas that are unilateral or one-sided. So yes, you would expect it to be more, but it's not definitely part of the prerequisite of that diagnosis.
Okay, thanks. What's your idea about the concurrent infection in this patient?
Say that one more time, I missed that.
Concurrent, what's your idea about the concurrent infection in this patient?
The concurrent, what? I don't catch the word after
infection.
Infection. His presentation wasn't an infectious presentation. He didn't come with a cough or with phlegm or anything. He was not febrile. If this was a diffuse, I'm trying to think through it. Could this be a very unusual presentation of a viral pneumonia? If I didn't have all that nephrology story, yes, I could have thought that. But that would be too coincidental to have someone come with all this complex nephrology story, and then suddenly they're getting this like horrible, like viral unilateral bronchopneumonia. Is it possible? Everything is possible. But I don't think a viral pneumonia or an atypical pneumonia would be my first diagnosis for this person. But maybe to answer your question in a backward way, for all these patients, when we have diffuse infiltrative disease like this, any kind, and they're this sick, they're on a ventilator, they're decompensating, going down like this, we empirically treat them, because many of these people who are not infected initially do get infected in the first 48 hours, because you have fertile territory, you have beautiful alveolar space with blood floating around, and they're in an ICU setting. So many of them get ventilator-associated pneumonias very quickly. So for most of these patients, there isn't any literature for it, but the clinical practice is that most of these we treat empirically with broad-spectrum antibiotics.
Yeah, that means you suggest it's better to use empirical broad-spectrum antibiotic for this patient. And in conclusion of your speaking, I get that you don't suggest any high dose of steroid or plasma exchange for this patient.
I didn't say I didn't suggest it. I said that I would treat the nephrological syndrome rapidly. If you would see this patient with severe acute on chronic nephritis, like is the patient, I mean, I'm no nephrologist and we have a smart nephrologist on the call, so I would not dare speak, but if this gentleman is presenting with severe acidosis, severe anemia, acute on chronic, and what looks like an acutely worsening picture of a chronic nephritis, I assume for that patient, for that picture, you would give a pulse of steroids. So I'm not prohibitive to it. But if this person did not have the nephritic picture at all, and you would simply see that X-ray, hypoxemia, and hemorrhage in one side only, and especially only on one lobe, no, I wouldn't give pulse steroids just for that.
Okay, thank you. And Dr. Ahmad, thank you for joining us. I have a question from you about this patient that we noticed that we have a patient with alveolar hemorrhage, local alveolar hemorrhage that, as Dr. Dawood said, is a blunt hemorrhage, and it's usually due to renal involvement and rapid progressive glomerulonephritis. And the history of the renal involvement 4 years ago with proteinuria and hematuria. What's your opinion? What's your differential diagnosis and your plan for this patient? Dr. Ahmad Pur.
Hello, can you hear me?
Yeah.
Okay. First, thanks for inviting me to talk here. First of all, as nephrologic point of view, when I'm exposing a patient with pulmonary and renal manifestation, there's a long list of disease that is starting with probably simply volume overload and pulmonary edema because of volume overload. And then you can have a patient with sepsis, ARDS, and renal failure. You can have interstitial nephritis, for example, due to Legionella, pulmonary involvement, renal involvement. So first of all, I have to separate which part of the kidney is involved. So as you mentioned, it is primarily glomerular involvement. So I'm going to a subgroup of these disease that is called Goodpasture syndrome. And then Goodpasture syndrome, you can, among them, you can classify Goodpasture disease that is due to anti-GBM and other causes of Goodpasture syndrome like vasculitis, ANCA-associated vasculitis, cryoglobulinemia, thrombotic microangiopathies, lupus. And so for me, the involvement is glomerular part. And I agree that it is not acute because there are many signs and symptoms that for me, it takes a long time for reaching at this level of clinical presentation. Generally, a creatinine of 30 milligram per deciliter, it is not acute. It takes time. And moreover, as Dr. Dawoodi mentioned, the hemoglobin of 4.5, if a patient has hemorrhage in alveolar with a hemoglobin of 4.5, it is already dead. And I have the high PTH, very high phosphor, low calcium, all are in favor that it takes time. And there is a urinary test in 4 years ago that it has proteinuria. It had proteinuria at that moment. So I think that it is a rapidly progressive glomerulonephritis. And now among the different involvements, of course, I will ask for anti-GBM, I will ask for ANCA, and you have a patient with mild rashes with skin involvements in the face and low complement, and probably antiphospholipid antibody syndrome. So for me, it is probably a post-infection, an immune complex mediated glomerulonephritis that cause rapidly progressive recovery. And still, I agree that the hemorrhage of the patient can be multifactorial from an autoimmune disease to uremia that takes part. And I agree that it must be dialyzed as is done, but a bit I'm not agreed to pass 8 units of blood in one day, because it doesn't need that much. So just would you? Could I respond to your question, or?
Yeah, thank you, Dr. Ahmadpour. I will ask you again in future. Dr. Baharwan.
Thank you very much. I'm
Sorry to interrupt you, colleagues, but there is a question that is asked from Dr. Davidi, which is about bronchoscopy, if it was a proper step after diagnosis of the patient, if it could be delayed after plasmapheresis, and if the patient could be followed by multiple CT scans. I would be thankful if you have your answer. Please, Dr. Davidi.
Those were, I think, 3 questions. Was the bronchoscopy appropriate and timely? Did the patient need serial CT scans? And I missed the middle one. What was the middle one? There was something in between. I missed that. Sorry.
It was asked that if it would be delayed and then serial CT scan would be substituted instead of doing bronchoscopy.
Okay, well, delayed, it was delayed. It wasn't done first. It was done kind of after they stabilized the patient. I think the way it's said in the presentation, it's that they first transfused and did what they needed to do, and then they did it. So it wasn't done immediately. Usually in the ICU setting, we don't do bronchoscopy if we think a bronchoscopy is not, number 1, life-saving, and number 2, it's going to lead to worsening refractory hypoxemia. There's a whole literature about that, and I don't think you want me to discuss that because that's mostly mechanical. But if you have an ET tube and you put a bronchoscope inside it, you just took away 2/3 of your lumen. Even if you go with a small scope, you're taking some of the lumen, and then you create airway turbulence and things like that. So we usually don't like to do bronchoscopy if, from an oxygenation perspective, our back is against the wall and we don't have a lot of room. I'm pretty sure they paid attention to that and didn't do that. Yes, it was helpful because, I mean, if this person, as you know, was not overtly hemoptysizing, so we didn't know what that infiltration looks like. So to know whether what you're looking there, is it blood? I mean, you would be surprised with things you find in patients. Sometimes you go in there and you see pieces of food. So the patient forgot to tell you that you're eating in the morning and they coughed and aspirated. So then that completely changes the direction of your diagnosis. So the data that bronchoscopy could add would really be helpful and would rule out a bunch of things and rule in a bunch of things, or at least make some things more likely. And about the serial CT scans, I don't know, serial, do you mean at this point in the presentation or in the future? Because we've already, we're 24 hours into the presentation. We've had 1 CT scan. I think that's sufficient. In the future, if you mean several days later, with this presentation, the man was extubated in 48 hours. So I don't think a chest CT was really clarifying anything because he improved. If I could get my wish list of anything I wanted, I would want a piece of lung tissue, but that would be too invasive at this point.
Thank you for your response.
And by the way, I really agree with Dr. Ahmadpour's suggestion. That's what I was thinking when I was reading too, that wow, they really gave too much blood. I would have never given this guy that much blood quickly, unless they had refractory hypoxemia that was not responding. Because as they're dialyzing the patient, they can give unit by unit and correct gradually. Again, it is almost impossible that he lost all that blood in the last 24 hours before he came to the hospital. So this is a very chronic and gradually forming process. So you can correct it gradually. And the fluid overload and other issues that would be created with giving someone 8 units of blood, even with dialysis, I think the harm is more than the good. And so I completely agree with him, and that's what I was thinking too. I wouldn't have given him that much blood that quickly.
I have a comment about your idea that when we have a patient with multi-organ involvement, drop in hemoglobin may be due to the multifactorial agents, such as maybe due to some parts from the and due to hemoptysis, some parts due to hemolysis. You know, if there is some immune complex or autoantibody in the blood, drop the hemoglobin to 4 or 5, maybe due to multifactorial, and that's why most of the drop is not due to hemoptysis.
I mean, if you the blood has to go somewhere, right? So we usually look for the blood in the body in the ICU. When we have drops, we look. There's certain parts of the body we know to look. We look in the retroperitoneum. We look in the thighs. There's places we look. We look in the GI tract. And if I remember correctly, he had his positive occult blood, but it was occult, and the stool was brown, so he couldn't have bled that much into his gut. If he had bled anywhere in his body, that amount, even half of that amount acutely, his bilirubin would have gone up in a few hours. He has a normal liver function. So with a normal bilirubin, you couldn't have bled 6 units. It's just impossible.
Okay, thank you.
Thank you very much. So in the next step, they prescribed methylprednisolone, 1 gram daily for 3 days. And on the second day, they had the result of the sputum culture, which showed few Klebsiella and negative testing for PCP, heterophil antibodies, antibody to streptolysin O, streptococcal DNase B, Treponema pallidum, and HIV. And after that, they administered antibiotics with a regimen of vancomycin, cefepime, and ciprofloxacin. Here on the second day, we have some other test results. As we can see in the CBC, the leukocytosis was cured. It's gone. The hemoglobin level is 10.4. Am I not clear? Do you not have my voice?
No, you're clear. I will fix the problem.
Okay, thank you. And the platelet count fell to about 134,000. The creatinine level of the patient fell to 16, and the other electrolytes are also showed in the table. And also we have 2 tests that is increased haptoglobin and decreased albumin levels, which both show systemic inflammation. So, Professor Faizi, are we going to? I think here we have the results that we need here. And I would like to ask Dr. Khosrowshahi if we have her here with us. Dr. Khosrowshahi, are you here with us?
Unfortunately, we have no Dr. Khosrowshahi with us. Can you hear me? Yeah. Okay. I asked a lot of questions from the invited speakers, and I think we can go on and ask a question from the population future.
Okay. I think my voice is echoed. here. So in the next step, the kidney biopsy was performed for the patient, and I would like to ask Dr. Afrouzian to help us with the kidney biopsy. Now I would stop sharing my slides. Dr. Afrouzian.
Good afternoon, everyone. I'm very happy to be here, and also let me tell you, very happy to see that females are leading this conference, 3 females, and that makes me very happy. Congratulations. So let me start. Do you have my picture here, the slides?
Yeah, we have the slides, and you can do, if you want, you can do the slideshow. Yeah.
Yes.
It's great. Thank you.
You're welcome. The pathology part, I am using some of my own slides because I thought the pictures from the journal are great, but maybe for presentation we will need a little bit pictures with better visualization. So I always start first with normal. I know it's boring, but we have to go through them to appreciate.
Excuse me, Dr. Afrouzian. Can I ask you first, can you, when you are talking about the pathologic findings, can you tell us that could you as a pathologist tell us that could you make a diagnosis of a rheumatic disease through a pathology, renal biopsy, or you need some more information from the serology to make a definite diagnosis? I want to tell us more about this.
Okay, you know, nephropathology is very, very close to clinic. So a nephropathologist cannot practice in a vacuum. We always have to have, even more than any other parts of pathology, more than tumor pathology, we have to have very good clinical history, very good communication with our nephrologists, and also as many tests as possible. The reason for that is that we have very small piece of tissue. It's a core biopsy, and we have a lot of expectations from that little piece of tissue. And nephrology has basically progressed more than any other branches of internal medicine in terms of pathology, in terms of bringing pathology into the first row by using immunofluorescence microscopy to show some data regarding the pathogenesis, what kind of immunoglobulin or complements are being deposited, and even further than that, electron microscopy to show exactly where the lesion is located. So it is always very much appreciated to have a lot of information. The differential diagnosis is broad, and sometimes, sometimes we don't get very good information. But if you are in a center where you have nephropathologists, I can tell you I'm closer to my nephrologist colleagues to my own pathologist colleague, because we work on a daily basis and we have to have a good communication.
Thank you.
Okay, so first of all, this is a normal glomerulus. So we use different types of stains to figure out what is happening in the glomerulus. This is a glomerulus by H&E, and as you might appreciate, all the peripheral capillary loops are patent, and whatever you are seeing here, very vague as pink material, is the mesangium, is part of the mesangium, and then you have cells here that some of them you might be able to say they are endothelial cells, like this one, for example. It is facing a space like this. But, or the bigger one, the biggest cell in a glomerulus is the podocyte. You can tell this is a podocyte, but really making a differential between a mesangial cell and an endothelial cell is very difficult in an HME. So that's why we need a PAS stain, which will tell us where exactly the basement membrane is and where the mesangium is located. As you see again, peripheral capillary loops are patent, and there is no crescent here in the Bowman space, and the cellularity looks normal. How do we say it's normal? It's because we don't have more than 3 or 4 nuclei in a single mesangial area. So the next stain that we routinely do is a silver stain. Different, variations of silver stain. This one is the PAMS, or periodic acid methylamine silver, where you can appreciate the real thickness of the basement membrane. Here you have a very thin basement membrane that it has a smooth contour. So this is what you would expect in a normal patient. Here we have now a glomerulus, similar to the glomerulus that you must have seen in the paper. And now with the introduction I gave you, you might appreciate peripheral capillary loops are not patent, and they have been replaced by a cellular proliferation. So this glomerulus is very hypercellular, and the cells, some of them are inflammatory cells, a lot of them actually are inflammatory cells, and they have the lesion that we call endocapillary hypercellularity. This paper was published in, I think, 2012. Since then, in 2019, there are some changes in how we will call these lesions. The consensus right now is that we have to call them endocapillary hypercellularity instead of endocapillary proliferation. This is a detail, but I just wanted to show you this. Here we have also wire loops. If you really pay attention, this area, the color is a little bit different from the rest of the capillary loops or rest of the tuft. It has a kind of, it's difficult to show by a picture, but it has a shining appearance. This is called a wire loop because under the microscope, it looks like a copper wire. It shines like a copper wire. And when we say wire loop is basically a board question for nephrologists, for nephrology fellows, because when you talk about wire loop, there is only a few diseases in which you would see the wire. We'll get to that when we get to electron microscopy to see what this wire loop is made of. Here is higher, not higher magnification, but a blow of the wire loop, and you can see it also here. The basement membranes here, basically the capillary loops are very thickened compared to the very first slide that I showed you by HME. And another thing is that we have a kind of lobular simplification of the glomerulus. That means that the glomerulus is kind of going to its fetal appearance. The fetal appearance of the glomerulus has a lobular appearance. So this is just a morphology that we appreciate. Now, in this picture, you have the glomerular tuft here in this area, but you also can appreciate the presence of a cellular crescent here. More than 2 rows of epithelial cells are here, which is the definition of a cellular crescent. And that is a sign that part at least of this process is acute and is very acute. However, we also have fibrocellular crescent in this area, which my colleagues also reference to the chronicity of this disease. Here we can see that this process has been going on for some time. There is some fibrocellular crescent. These are the cells and these are the fibrous elements of it. So I can tell by this glomerulus that this process has been going on for some time. Another thing that we can see with our silver stain is the presence of double contours. So what are double contours? Double contours are kind of a reaction of the glomerular basement membrane to injury. It's as you might appreciate here, we have two lines where we should have only one line in a normal glomerulus. This is called a tram track or railroad, or the more common expression is double contour. And this is a sign that doesn't happen very acutely. It happens maybe 2, 3 days, 4, 5 days after, or maybe more after the first insult has occurred to the glomerulus, and this is one of the reactions of the GBM. These three pictures are from the paper. I did not have better than these in my collection. So here you might appreciate with a different stain that we have a lot of interstitial fibrosis. Everything that is in blue is interstitial fibrosis and tubular atrophy. These are the sizes of normal tubules. And you see that there are small tubules here. Those are the atrophic tubules. So that is also another sign of chronicity. Now, two other lesions are present in this patient that are very interesting. One of them is that they found in an arteriole. So if this is your arteriole, it's really difficult to figure out where the lumen of this arteriole is. Maybe this was the lumen, but right now it contains a thrombus. So there are thrombi within the arterioles, and also if you are paying attention to this arteriole, this is the lumen of an arteriole, and you can see that the red blood cell has gone underneath the endothelial cell. So it's extravasating. There is so much endothelial injury in this arteriole that the red blood cells or fragments of red blood cells kind of are projected towards the periphery of the arteriole. Now we go to the immunofluorescence, because immunofluorescence microscopy is going to reveal to us what is the pathogenesis of this process. So by immunofluorescence microscopy, this is the contour of a glomerulus. And as you might appreciate, there are granular deposits of IgG. This is stained with IgG, but basically we know that they have stained it with IgA, IgM, C3, C1q, kappa and lambda, and all of them showed the same picture. Presence of confluent areas, ribbon-like areas of positivity, along with granular positivity here. These are basically areas that correspond to the wire loops that I showed you. If you want to put these two pictures, one on the top of the other, the wire loops will fall in this area. So positivity of all immunoglobulins and C3 and C1q happens only, I cannot say only, but really 99% of the time in a specific disease. And that's why we have a name for it. We call it full house pattern. Full house, like, you know, playing poker and then having a hand that is full house. So this is a full house pattern when you have all of these immunoglobulins involved and positive. We can talk about it later, what that means, but that means that there is excessive production of immunoglobulins, and that C1q positivity also tells us that that there is a specific activation of the complement pathway, and the location of these deposits are important. They are along the capillaries and within the mesangium. One other important finding that, again, is mainly found in probably two diseases is the position of immunoglobulin along the tubular basement membrane. Along the TBM, when you see these granular deposits here, this is very alarming about a specific disease. Now let's go to electron microscopy. This is just for your orientation. This is what is remaining from the basement membrane. This is inside the capillary, and here we are outside the capillary. And you can appreciate presence of electron-dense, massive electron-dense deposits in different positions. Some of them are within the mesangium in this area. Some of them are subendothelial, as you might appreciate here. There is, here you can see within the basement membrane, there are electron-dense deposits and rare subepithelial. This is the epithelium here, and this is the subepithelial area. So whatever process that is, it is producing a lot of deposits. And these deposits that are subendothelial, actually, they represent the wire loops. They represent those confluent deposits that you have seen by fluorescence microscopy. And the double contours that I showed you by silver stain, this is the double contour. So I'm trying to put the three images from light fluorescence and electron microscopy in your mind, juxtapose all of them together for you to realize what we are talking about. On very higher magnification, the deposits have a curvilinear appearance. You know, deposits can have multiple different appearances, and from their appearance, we can appreciate their characteristic, basically. These fingerprint deposits are cryoglobulins. So you see, cryoglobulin has multiple features. This is one of the features of cryoglobulins. Again, this is a board exam question. In the cytoplasm of the endothelial cells, we see tubular reticular inclusions. And if you read the paper, it says that we don't know exactly what they are. Maybe at that time we didn't know, but now we know that tubular reticular inclusions are signs of high interferon in circulation. You can see it in many different patients. You can see it in HIV positive patients, in COVID patients, in lupus patients, in patients with parvovirus B19 infections. So these are nothing but a sign of high interferon in circulation. At this point, I think all my presentation is complete. I'm not going to tell you about the basically diagnosis. I will leave that part for the clinicians to discuss. And if there are questions, I will be happy to answer.
Thank you, Dr. Afrozian. Thank you very much for your nice discussion about the pathology findings. Dr. Baharman, please go on.
Okay, thank you very much. So we had the kidney biopsy, and also we have the serology results. Actually, they were taken at the admission time of the patient, and now they are ready. We have FANA positive results with a titer of 1 to 1,200 with the homogeneous pattern, and also we have the anti-dsDNA positive with a titer of 1 to 80. Anti-cardiolipin IgG was also positive. The C3 and C4 levels were decreased, and RF, anti-histone antibodies, ANCA, MPO, PR3, and anti-GBM were all negative. And also, while still in the hospital, the platelet count of the patient fell to 90,000. Okay, Professor Faizi.
Okay, thank you. Now we have a patient with alveolar hemorrhage. That the etiology of the alveolar hemorrhage is undetermined so far, and rapid progressive glomerulonephritis and positivity of some autoantibodies such as FANA positive anti-double strand DNA and low C3 low complement, and history of false positive RPR and high level of PTT and presence of the glomerulonephritis and presence of the intratubular, intravascular thrombosis in renal biopsy. That all of them shows the diagnosis of SLE with antiphospholipid syndrome. And now I have a question from Dr. Ahmadpour. Dr. Ahmadpour, so far, what's your treatment plan for this patient? There are some evidence that some treatments such as mycophenolate have the same effect as cyclophosphamide. But for severe cases, now there's a recommendation for cyclophosphamide, and sometimes urolupus and sometimes high dose of cyclophosphamide. And now, could you tell us your opinion about for treatment of this patient? Dr. Ahmadpour, please.
Yes, just to mention that on admission, the results of complement C3 and C4 was ready, and I think that because of it was a CPC, they hidden the results of anti-DNA and anti-nuclear. So, as Dr. Afrozian mentioned, clearly, I don't know that how percentage of the glomeruli was affected with crescent. It is not mentioned. So for me, definition of crescentic glomerulonephritis is at least I have more than 50% of glomerular to be crescent. So overall, with the pathologic point of view, with full house pattern, with proliferative lesion, and with C1q, for me, it is an antibody immune complex mediated complement activation, and it's an immune complex mediated disease with right now with complement and anti-DNA. Most probable diagnosis is severe lupus nephritis. That it at the same time it attacks the pulmonary organs. So in terms of treatment, what is changed since 2012? We have voclosporin in our hand, we have belimumab in our hand, and what is still changed is the dose of steroid in terms of the treatment of lupus. The dose of the steroid nowadays we're using much less lower doses that we used, both as pulse and as maintenance therapy. And we know very, very well now that for the genomic actions of steroids, 30 milligram of prednisolone suffice. So in contrast to 10 years ago, that I kept my patients on 1 milligram per kg for 1 month, I reduce it much more rapidly. And for the case, well, of course, the methylprednisolone is the main place for reducing the inflammation. As you mentioned, Cellcept, cyclophosphamide, it's not for today or tomorrow. It works some days later. I will the study that showed that there is no inferiority in Cellcept compared to cyclophosphamide. The mean of serum creatinine was 1 milligram per deciliter. There are some much little study that show that Cellcept may work with some renal dysfunction, more severe than original study. But I agree that we have to use cyclophosphamide instead of Cellcept. But again, about the dose of Cellcept, they prescribed the high dose of cyclophosphamide, but the patient hadn't received it. For me, the treatment will be steroid and cyclophosphamide, but I'm wondering whether I have to do plasma exchange at the first days, at the first day for these patients. But of course, I will ask for the alternative pathways, the factor H, factor B, factor I, anti-factor H. I will ask for Adams 13, and I'm thinking about the catastrophic antiphospholipid antibody syndrome.
Thank you, Dr. Ahmadpour. What's your idea about the hydroxychloroquine prescription for this patient? Do you think it is necessary or not?
Well, of course, hydroxychloroquine is shown that is effective not only in lupus, but nowadays in many other autoimmune disease. The dose is between 5 to 6.5 milligram per kg, but still it's not the acute critical treatment. Of course, he has to take it, but it's not acute in our acute setting.
Okay. Thank you, Dr. Ahmadpour. As you mentioned, we use high dose of steroid for suppression of inflammation, and then use immunosuppressive to prevent the progression of the disease. And despite the presence of some study that showed that mycophenolate may be equal to the cyclophosphamide, we know that those studies didn't include severe patient with severe renal involvement. And so for the severe cases, now there's a recommendation that we have to use a high dose cyclophosphamide, not even Eurolupus regime. So, and as you mentioned, hydroxychloroquine can be prevent from the lupus failure and can protect from long-term renal damage. It's very important. A few years ago, there was not this recommendation, and when we used immunosuppressive such as cyclophosphamide, there was no need to use hydroxychloroquine. But now we notice that we have to use it, and there's recommendation to use hydroxychloroquine for all of the patients. And the other treatment that we have to use for this patient with intrarenal thrombosis and positive antiphospholipid antibody is anticoagulation, that we have to use it for long term, and that in the future we can see that it's used for this patient as well. Now I have a question from Dr. Davudi. Dr. Davudi, if this patient has had a usual presentation of the pulmonary and alveolar hemorrhage due to, for example, capillaritis, due to SLE disease, what was your suggestion for the treatment of this patient? Do you think that high dose of steroid or IVIG or plasmapheresis or cyclophosphamide, which one of them necessary for the treatment of the alveolar hemorrhage in SLE? Dr. Davudi.
Yes, I heard you. If we had the pattern that, as Dr. Ahmadpour nicely mentioned, was pointing us towards an anti-GBM. First of all, let me mention something that maybe I misrepresented something or said it too slightly. The bland type, one of the differentials of the bland type alveolar hemorrhage is also lupus. I mean, you do see bland type. It's been mentioned as one of the differentials. So this does not go against the diagnosis of lupus, or it's not a mismatch like true and unrelated. It's not like that. But for the reasons I explained, I don't think this applies to this patient. But back to your question, if this was a classic anti-GBM-like disease, or it was in some other diseases like what we used to call Wegener's or other diseases that are basically immune-mediated or posse-immune capillaritis, yes, for sure, the classic regimen of 0.5 to 1 gram of steroid per day for the first 3 to 5 days, and there's again different studies with different regimens, and none of them have really shown. I sent a few case series and studies to Dr. Baharvan. Unfortunately, I only got to studying this, believe it or not, at 1:30 a.m. last night. So at that point, I did my lit search and sent a few papers to her. I don't think it got to everyone yet. But I just looked at this case series, and this is again not my cup of tea, as you know. I'm an interventional pulmonologist, but from what I read, the most important studies that have larger numbers show that there isn't really a major difference between 0.5 to 1 gram, and there isn't a major difference between 3 and 5 days. There was no good head-to-head comparative studies between cyclophosphamide and the other, like mycophenolate and the other immune modulating medications. As Dr. Ahmadpour was nicely saying now, there are new case series and case studies coming for the monoclonal antibodies in this disease. But again, from a purely respiratory disease perspective, yes, I would have gone with the steroid regimen that he was given if I was convinced that he has capillaritis. And Dr. Ahmadpour beautifully mentioned it from my field too, that what we give in terms of steroids now is much less in inflammatory lung disease than it was 10 or 15 years ago. We've discovered that that extra margin really does not confer a benefit to us. And to plasma exchange has shown in refractory disease, meaning after 48 hours, you don't see any improvement in hypoxemia. You can try plasma exchange. Plasma exchange is usually not the first arrow in our quiver, if you will. And the reason for that is because it has its own complications. And for plasma exchange to be successful, we have to also give a touch of anticoagulation with a patient who's already bleeding into their lung isn't the first thing we want to do. And so we don't go to plasma exchange as our first step. But if after 48 hours we see no benefit from immune suppression, we do institute plasma exchange or apheresis. We often use apheresis here for 3 to 5 regimen sessions.
Okay, thank you. What about the IVIG?
IVIG, I don't have experience with, and I looked at the literature and it didn't seem to be very convincing. But again, I cannot tell you from personal experience or knowledge. I'm sorry. I claim ignorance on that one.
Yeah, thank you very much. As you mentioned, the first step of treatment for alveolar hemorrhage is the high dose of steroid. And there are some studies that in SLE patients with alveolar hemorrhage, the use of the higher dose of the steroid, that conventional dose that we use 3 gram in 1 gram for 3 days. When we use 4 to 8 gram, they have better survival rate than 3 gram. And for cyclophosphamide,
how much was this new one you said?
4 to 8 gram
Per day?
Patient with alveolar, totally.
Over 8
for
days
one,
or over 3 days?
No, for 8 days.
Oh, so
1 gram
a day for
daily,
8 days. So extending it
yeah.
instead of 3 days to 8 days.
Yeah, it's mentioned that it's recommended that we have to use high dose of steroid until the cessation of the hemoptysis and improve on the manifestation of the patient. And about the cyclophosphamide, it's recommended for most of the patients with alveolar hemorrhage, especially patients who need mechanical ventilation as well. And for IVIG, there is no good recommendation, strong recommendation, and just it's recommended for patients with concurrent infections, disease, that we can use high dose of steroid for this patient. And about the antibiotic, there was a study on diffuse alveolar hemorrhage on SLE patient that showed that around 57% of the SLE patient with alveolar hemorrhage has infectious disease, and the most cause of the pulmonary involvement in SLE patient is infection overall, not in individualized. And it's recommended to use antibiotic therapy, broad spectrum antibiotic therapy, as like empirical therapy for all of the patients that we start steroid for the treatment of the alveolar hemorrhage. And for plasma exchange, as you mentioned, there's a recommendation that we have to use for patients who respond not inadequately to the high dose of steroid and cyclophosphamide. And there are some results from the different studies, and there was a variety of the results. Some studies shows that it can improve the survival, and 2 studies shows it can increase the rate of the mortality with odds ratio of around 7.6. And it means that different results and variability of the results may be due to different severity of the patient who need plasma exchange as a treatment of the alveolar hemorrhage. Thank you, and we are going to continue this case with Dr. Barwan, please.
Okay, thank you very much. Okay, about the plasma exchange, at 2 times during the admission, they had transfusion medicine consult for the patient. Firstly, after the diagnosis of alveolar hemorrhage, they did a consult, but it was not confirmed due to dramatic improvement after the administration of glucocorticoids. And secondly, after the positive anticardiolipin antibodies with pathological evidence of thrombotic microangiopathy, and again, it was not confirmed to do the plasma exchange for the patient. So the consequent events that happened to the patient, he was quickly weaned from mechanical ventilation and was extubated within 48 hours after admission, and he was transferred out of the ICU on the 3rd day of admission. The administration of prednisone was with the dose of 60 milligrams per day was begun, and also he was anticoagulated firstly with low molecular weight heparin and followed by transition to warfarin after that. And also they had the plan of 500 milligrams of cyclophosphamide IV every 2 weeks for 3 months, followed by 50 milligrams orally daily for the patient, and he got the first dose while he was in the hospital. And on the 11th day, the patient was discharged with outpatient hemodialysis. Okay, shall I continue, Dr. Faizi, here? Yeah. Okay. Thank you. So on the follow-up, unfortunately, the patient did not follow up with the rheumatology or nephrology clinic, and he did not get his planned cyclophosphamide infusions, but he did go to his hemodialysis, outpatient hemodialysis sessions. And at the dialysis clinic, they prescribed him with oral cyclophosphamide with a dose of 50 milligrams per day and prednisone with a dose of 20 milligrams per day. The patient adhered poorly to the medications. He declined to take the warfarin, and he discontinued his cyclophosphamide after 6 months. Well, fortunately, after several months of dialysis, his urine output resumed, his creatinine level declined, and his dialysis was reduced to twice weekly sessions. And after 15 months, they did discontinue his dialysis sessions and his prednisone. And finally, after 7 months of this continuation of his dialysis, his creatinine level reduced to 3.26 milligrams of deciliter. Okay, Professor Faizi.
Thank you, Dr. Baharvan. I have a question from Dr. Ahmad Poor. Do you have any experience with the patient, like this patient, that have a history of the renal involvement in a few years ago, and now present with acute and chronic glomerulonephritis, and you know, if we don't treat lupus nephritis, the patient has a worse outcome, and they usually present other manifestation of the disease. What's your experience about the lupus nephritis?
I think Dr. Ahmadpour is not here. Ms. Sadeghi, can you do the favor to find and give access to Dr. Ahmadpour for the speaking?
Sorry, unfortunately, I can't find Dr. Ahmadpour in the room.
Okay, thank you. Thank you. Professor Faizi, we do not have Dr. Ahmadpour here at the moment.
Yeah, there are some questions from the audience that one question is about any role of the rituximab for treatment. Dr. Dawoodi, do you have any comment for this question?
Rituxan has been tried both for inflammatory diffuse alveolar hemorrhage and for diffuse alveolar damage, Hammond-Ridge syndrome, with controversial outcomes, meaning some people have reported better outcomes than others. And I really don't know that it, again, I'm not an inflammatory lung disease specialist. I said that when you contacted me first. I don't know whether that is a current recommendation. When I looked up, I saw that the studies have not shown a conclusive benefit for Rituxan, either in inflammatory diffuse alveolar hemorrhage or Hammond-Ridge syndrome acute interstitial pneumonia.
Yeah, thank you, Dr. Dawoodi. And there are some studies that recommend rituximab for alveolar hemorrhage due to lupus. But because of the late onset of the rituximab to effect on B cell and reduce the level of the antibody, it's not recommended as a treatment in the acute phase of the disease. It's recommended for such as maintenance therapy to decrease the level of the antibody.
As you know, some people with diffuse alveolar hemorrhage have recurrent episodes. Some of them are in inflammatory connective tissue disease or vasculitides like Wegener's, and some of them are in other syndromes like idiopathic pulmonary hemosiderosis, which we usually see mostly in children and young adults. And in those people, Rituxan is commonly a preventive measure for recurrence. Yes.
Yeah, thank you. The other question is that is alveolar hemorrhage due to ATS or capillaritis? Alveolar hemorrhage in SLE can be due to capillaritis or bland hemorrhage or even antiphospholipid antibody, and that sometimes there is anti-GBM or sometimes ANCA that we can see in patients with systemic lupus erythematosus, that a patient can have the combination of these effects, and for this patient, we have to use anti-inflammatory drugs, immunosuppressive, and anticoagulation to prevent all of the pathogenesis of the alveolar hemorrhage in this patient. Dr. Dawoodi, Dr.
Sorry, I listened to that, but I didn't.
Yeah.
What was the question? I didn't catch the question.
They asked that alveolar hemorrhage in this patient can be due to antiphospholipid antibody or due to capillaritis.
Well, we already discussed the capillaritis versus bland and the evidence on the two sides of that. And unless we're in the person's lung or we have pathology, I don't think we can say definitely one or the other. I told you what my hunch is. For the antiphospholipid syndrome, do we have an antiphospholipid titer for this patient? I didn't catch that.
Yeah. This patient has
positive?
a high level of
Okay, sorry, I missed that. I apologize. Yes, then that could be an element too, especially with the, I think Dr. Afrouzian was mentioning the microthrombotic element also, which again goes with the antiphospholipid syndrome. So for sure, if you have that in the kidney, of course you can have it in the lung too. It's a systemic condition.
Thank you. Dr. Afrouzian, do you have any comments?
Sorry, I have a few comments. The first thing is to agree with Dr. With Pedram, basically, regarding the fact that the number of crescents are important, the proportion of crescents. Also, one thing that was not very clear in this report was the proportion of glomeruli that had endocapillary or cellular proliferation, the type of cellular proliferation that we are looking for, because that differentiates between class 3 and class 4 lupus nephritis. Also, I just wanted to say that Dr. Ahmadpour had a problem with his battery. That's why he got disconnected. And then when he wanted to reconnect, there is a message that says on his screen that that he is locked by the organizer. So if you could unlock him so that he could respond to his questions. Thank you.
Thank you very much for all of the invited speakers. We appreciate your time and your time. And thank you all of the audience to have with us. And I hope to discuss this discussion will be informative for them and to help them for the resolution of the problem with their patient in practice. Thank you very much. If there is no any question, we finish this session.
Thank you very much. It was a wonderful opportunity, and have a good day, everyone.
Thank you so much, and probably see you again.
I would like to thank all of you for participating in this session. It was really informative and exciting for me myself. And I also want to appreciate the World Lupus Day, which was actually yesterday, the 10th of May. And this is actually the Azadi Tower, which turned into purple last night in appreciation of World Lupus Day. Thank you very much.
Thank you, and hope to see you in the next session as well.
Thank you, everyone. It was a great honor for me to participate in this great meeting. Please help us with filling the form that I've shared in the chat box to send your feedbacks. Everybody have a great day.
Thank you.
دکتر افروزیان، دکتر داوودی، دکتر احمدپور، خیلی ممنون به خاطر تشریف فرماییتون.